I thought I'd talk a little bit about what's been on everyone's mind, which is obviously COVID-19. Talk a little bit about imaging techniques and imaging findings, just as like an overview. So, just like with any pneumonia, really the first step in evaluation after clinical evaluation is going to be chest radiography. But obviously there's been a lot of excitement about CT imaging in these patients because there are typical imaging findings on CT, but we really want to emphasize that CT is not really the go-to modality in these patients for a few reasons. One is obviously safety. We don't want to expose more parts of the hospital, more rooms, and more people like our technologists to these infectious patients. The other thing that, as we'll get into, is that the imaging findings are non-specific and they could reflect a number of different entities, and we don't want to be overconfident about our diagnosis, particularly in areas where the epidemic has not reached truly epidemic proportions. So I'm showing you here just a sort of background reading, a nice article in The Lancet, which goes through some of the typical imaging manifestations on CT. And so we'll talk a little bit about that in a bit, but this is a good sort of background reading if you're interested. But let's jump into some X-rays first. This disease, COVID-19, just like with many viral pneumonias, tends to give a sort of interstitial pattern. It's what people used to refer to as interstitial pneumonia. Now we know on CT that the finding is not truly interstitial in these cases. It's usually manifested as ground glass, but the X-ray has a sort of interstitial pattern, and so that's what many people used to refer to as interstitial pneumonia. So you can see, as in this patient, we have diffuse interstitial opacities distributed throughout both lungs. There's maybe some consolidation in the lower lung zones. Of course, this patient is intubated. This is a pretty typical appearance. I'll show you another one, also with interstitial opacities. You can see here a little bit more in the upper lungs and middle lung zones in this patient. Now the other feature, and this is something that we see on CT and we'll get to more later, but you can sometimes actually appreciate it on the chest radiograph, is a peripheral distribution of the interstitial opacities. Like in this patient, you can see sort of a striking peripheral predominance of this relatively symmetric airspace process. So you can see obviously these chest X-ray findings are not specific, and just as a fun mimic here, I'm going to show you this case. This patient also presented with fever and dyspnea, and you can see here somewhat more central sort of perihilar interstitial opacities with a subtle nodular character, and you can see some hilar enlargement as well. And this patient actually has sarcoidosis. So obviously there's a very large differential diagnosis for the chest radiographic appearance, but you should get a sense of what you're kind of expecting to see. Now, we go to CT. I'm going to again just sort of reference this paper briefly. You can see that the most common findings are ground glass opacity, as I say here, typically is bilateral. Peripheral distribution was sort of the plurality, or actually majority of cases, but it does not have to be peripheral, and tends to have a lower lung predominance. In this series, they describe the right lower lobe, but in general, both lower lobes. That's the most typical appearance. Early on in the course, it may be unilateral, but then later on, you tend to get bilateral and more extensive opacities, just like with any sort of worsening infectious process or inflammatory process for that matter. So I'll show you some examples of typical and less typical cases. In this case, this patient who was imaged early on in the course of their disease, here you have some patchy ground glass opacities within the right upper lobe, including a reverse halo sign here with central clearing and kind of peripheral consolidation. Again, some more patchy opacities, a little bit in the left lung, but it is sort of rather asymmetric early on in this patient's course. This patient had a relatively benign course to their disease. So they were not re-imaged, but you can see that early on it can be asymmetric, but the reverse halo sign was described in a number of these series. It is a feature that we tend to think about more with organized pneumonia, but in many cases, organized pneumonia is actually a reaction to some process, for example, viral pneumonia, like in these patients. Now here's another example, and this CT is of a patient with a lot more extensive disease. And you can see quite diffuse and extensive ground glass opacities throughout both lungs. A little bit of septal thickening here and there, but pretty extensive. And in this case, the opacities are in fact not particularly peripheral at all. In fact, they're more central, if anything. There are some areas where you think you can see a little bit of organization going on. Again, here you get a little bit of sort of contraction of the opacities. This perilobular sort of appearance that, again, is something that we tend to think of with organized pneumonia. And this virus generally gives sort of an organized pneumonia-like pattern on imaging. In this case, of course, it's pretty symmetric bilateral in this patient who was imaged in a more severe phase of their disease. But again, we should remember that while these imaging features can sometimes be suggestive in the appropriate clinical context, there's obviously a large differential and depends on your clinical history. And so I'll show you several examples of other cases that would sort of fit with the what's typically described for COVID, but are in fact other diagnoses. So here we have a case that also presented recently. With some patchy ground glass opacities here, a little area actually of central clearing, some more patchy ground glass. Now, of course, this case happens to have a more central distribution than the sort of typical peripheral distribution that's described in the literature for COVID. But as we saw, you can have patients with central distribution, like in the one I just showed you. So, I mean, I don't think that you could necessarily conclude much. This case is a case of human metapneumovirus pneumonia, which again, you might wonder in the current era, in an area that is experiencing an epidemic, would people suggest that this was COVID? If you didn't have a test available, there's no way you could really know for sure. Here's another case of a patient who presented with low-grade fever and chest pain after recent travel. Oops. You can see some peripheral ground glass opacity in the right upper lobe, and then we have some additional peripheral ground glass opacities in the right middle lobe. Maybe a small area of central clearing in this one. And so these are pulmonary infarcts, not viral pneumonia. The patient later underwent a PE study to prove that. And then I have one more example. Patient with actually consolidation, patchy but quite extensive, asymmetrically involving the left lung greater than the right, Some areas are central, but predominantly peripheral consolidations. There are areas of central clearing here. Notice that this consolidation spans the major fissure. This patient had peripheral eosinophilia, and this is chronic eosinophilic pneumonia. But again, you could imagine, depending on the extent of COVID disease in your catchment area, if a patient presented with fever and had this appearance, even though these consolidations are denser than the quote-unquote typical COVID description, would someone suggest COVID infection for this kind of an appearance? But again, this is eosinophilic pneumonia, not an infection at all. So again, while we see typical imaging appearance, we've described atypical imaging appearance in the literature. It's important to remember that patients with COVID may not have typical imaging appearance, and in fact, early on in disease, the CT can be normal, particularly in patients who are less symptomatic. CTs may be normal in maybe almost half of the patients. Certainly later on in the patient's course, their CT becomes more abnormal, which is what one would expect for any sort of progressive infectious process. And it's just really important that we don't forget our differential diagnosis for all of these appearances, because patients, even in the age of COVID, and even in epidemic in areas experiencing epidemics of COVID, patients may still have other diseases, including pulmonary edema, right, and alveolar hemorrhage and organizing pneumonia. And so it's important to keep kind of a broad differential, particularly if you don't know if the patient has a COVID infection. And so our general guidance to radiologists would be that, of course, if the clinical team, if they know the patient has COVID infection, then presumably they're doing imaging to look for some sort of complication. There's no role for routine imaging at this point to evaluate these patients. If the clinical team suspects COVID-19, then if the imaging appearance is the typical imaging appearance described in the literature, I think we could say that this would be compatible with COVID-19. Again, giving a differential as appropriate for the clinical scenario. But we have to be a little bit careful in cases where the diagnosis is unknown, that we do not necessarily jump to COVID-19 as the diagnosis, without really thinking about what the differential might be. We don't want to overburden providers with, all of the implications that come with this sort of questioned diagnosis, unless it's really necessary. Now, that's not to say if you do see, even in a patient where it's unsuspected, a patient with chest pain coming into the ER, or alcohol withdrawal, or some other cause where they're presenting, and imaging appearance is typical, it's certainly something worthwhile at least discussing with your referring physician, making sure that they're aware this is a possibility. Whether or not you should actually put it in your report, I think depends a lot on what the clinical team, what they're thinking and what the probability is. If they haven't known some other diagnosis that makes sense, that fits, then there's probably no reason to rock the boat. But it is definitely worthwhile having conversations with our physicians. I think that this infection really brings out how important it is to have a relationship with your referring clinicians, and have a discussion with them about what's going on with their patients. Anyway, I hope this was helpful. Thanks for listening.